Today's topic. Today's topic will be golf injuries, what they are, how to prevent them, how to avoid them, what things you can do to make them feel better if you do suffer for some golf-related injuries. So my name is Ricky Singh. I am Vice Chair in the Department of Rehab here at Weill Cornell at New York Presbyterian. I will be serving as your moderator today, and I am very excited to introduce my two speakers. The first is Timothy Caputo. Timothy is a physical therapist here in New York City, working with Spear Physical Therapists. If you are a patient of ours here at Weill Cornell at the Spine Center or at Brooklyn Methodist, there's a good chance you have seen one of our fine physical therapists at one of the Spear locations. Tim's also certified by the Titleist Performance Institute, which specializes in patients who suffer from golf injuries. So very excited to have him join us. And our other co-guest speaker is Dr. Caroline Lee. Dr. Lee is a sports medicine specialist, spending most of her time at our New York Presbyterian Brooklyn Methodist locations, working with patients who suffer from a variety of conditions: arthritis, tendonitis, shoulder, hip, knee, back pain, anything sports or spine related. She is your go-to person. So if you are in Brooklyn, you do not need to cross the water to come see me in the city. Please call her and see her. So I'm going to share my screen and I will advance the slides for everyone. You guys can see the screen okay? Good. All right, we'll start with Dr. Caroline Lee and then we'll go to Timothy Caputo. Go ahead, Dr. Lee, take it away.
Yeah, so pleasure to be here. Thank you for the wonderful introduction. So I just wanted to go over some general anatomy with all of you to start. Elbow itself is a hinge joint, meaning that it's supposed to only really do one direction of motion, but it's a unique hinge joint because it's made up of 3 different bones. The humerus is the bone that attaches from your elbow to your shoulder, and you have 2 bones in your forearm, the radius and the ulna. And these are kind of special joints in their own way. I wanted to highlight it using this picture, so it also shows kind of the front and the back aspect, which we call the anterior and posterior view. On the anterior view, you can see the humerus, the larger bone of the elbow, as it comes down, makes something called a capitellum, which serves as a large hinge for the ulnar bone, as well as the radial head, which just adds some support and stability in this area. From the posterior view, or the back side of the elbow, you always feel that bump kind of at the back of your elbow when you're kind of whacking into things. And that happens to be your ulna. So it's a projection of the ulna itself, and it goes into something called an olecranon fossa. So the humerus has space in the joint itself to make sure that that elbow bump can have somewhere to move, kind of shift whenever you flex and extend your elbow. Next slide, please. So like I mentioned, the elbow is a very unique hinge joint, because normally a hinge joint is only supposed to have this flexion extension motion that you could see at the very bottom of that picture on the left. It also provides supination and pronation because you have those 2 bones in the forearm, which allow them to kind of twist over each other. The radius itself is a slightly thinner bone than the ulna itself, and allows for what we call supination pronation, so bringing your hand so your palm is up or bringing your palm down. This requires some additional supporting ligaments for that additional motion in the area. And then most of the muscles in this area actually attach right at those medial and lateral epicondyles, or those bony prominences that you can kind of always feel in your elbow when you're feeling the outside and the inside of your elbow. Next slide, please. So I just threw this slide in there because I wanted to demonstrate that because of the complex nature of this joint, the ligaments aren't basically straight up and down or left and right. A lot of them cross over the joint, a lot of them will cross over the certain bones to provide more stability. And oftentimes that means that we could injure these ligaments, unfortunately, a lot more easily than we could in a different joint that would just be a normal, simple hinge joint. Next slide, please. Like I mentioned, we do have a number of muscles that attach into this area. On the left, I put in a picture of the muscles that we could see kind of if you're looking at it from the front of your forearm. And a lot of these muscles are related to flexion. So making sure that your wrist kind of moves forward, so your palm kind of goes in and down. And a lot of those muscles actually attach and combine into a common flexor tendon and attach into the medial epicondyle. One additional muscle that's responsible for bringing your palm downwards, called the pronator teres, also attaches into this area and is technically part of the common flexor tendon, but is also adjacent as far as muscles go to the larger complex of muscles that are related to making sure that your wrist is able to flex appropriately. You can see also on the slide, it's labeled below. Oh, sorry, we can go back. Next slide anyways. So who's at risk for elbow injuries, especially medial epicondylitis in golfers? We usually say around the age ranges of 45 to 64. It's about even in far as distribution, although I think there are more male golfers than female golfers right now. And interestingly enough, 90% of the cases actually occur outside of sports participation. And a lot of them deal with occupational settings that require forceful gripping. So a lot of people who do heavy labor, a lot of people who do repetitive motions, maybe an electrician or a mechanic using a screwdriver kind of continuously. There are few sports that are associated with medial epicondylitis. One of them in particular is baseball, which actually relates to that pronating motion. So bring that palm down as well as some wrist flexion. And then other sports that are associated have repetitive overhead movements like throwing or movements that are heavily reliant upon grip. So weightlifting, as you'd expect, it actually is one large part of it because you're trying to grip your barbell as hard as you can when you're deadlifting. Sometimes it requires an extra grip for when you're doing overhead press and that kind of thing. Other throwing and overhead movements like javelin, tennis, and racquetball also go into this. And you might say, hey, tennis is in there, but there's also something called tennis elbow, which is slightly different. It's on the other side where your extensors meet into the lateral aspect of your elbow. But we found recently that a lot of them kind of coincide. There's been some changes in the way the sports are played. And so a lot of tennis players will also have medial epicondylitis as well as lateral epicondylitis. And a lot of golfers will also have medial epicondylitis and lateral epicondylitis, meaning inflammation into the joint, into the bone where all of these tendons kind of meet and attach.
You know,
The prevalence
Dr. Lee,
in
you mentioned something about, you know, we call this golfer's elbow or medial epicondylitis, which is inflammation of the tendon. Of the people that you see in your clinic, of all the patients that suffer from this condition, how many of them actually play golf and have it from golf or have it from some other cause?
The vast majority have it from some other cause. I would say about 90% of my patients who I do see with medial epicondylitis are from occupational settings.
Did you kind of know what the kind of history is, why they started calling this golfer's elbow? And even in my practice, I agree with you. The majority of the patients that suffer from it don't play golf. They do something else, screwdriver work, or, you know, that kind of work.
So it originated because most casual golfers were starting to get it, and it's because there's some differences in the swing and the way it actually impacts. We have it on the next slide actually of showing like kind of the biomechanics of everything. And so when people are starting to learn how to golf, their biomechanics aren't quite right, and they don't quite have the swing down of where the impact should be. And a lot of times, actually, when you do strike the ball, it causes a sudden deceleration force, which gives more strain at the medial elbow. So like on the inside, where all those tendons do attach. And so if the form is a little bit off, then the force isn't quite distributed evenly between the medial and the lateral epicondyle, between the leading arm and the back arm. And because of that, it causes more irritation that kind of just builds up with time. So in casual golfers, the incidence of medial epicondylitis is 25 to 30%. And actually professional golfers, it's only 77 to 10% because presumably they've had better biomechanics, they've had form training, all this kind of stuff. And medial epicondylitis in that aspect is actually a lot less common than lateral epicondylitis, but it's still prevalent in golfers as a larger population.
Does it typically affect one arm
sorry.
versus the other, the dominant arm or the opposite, depending on what side you swing with, I guess, for golfers?
It's usually the trailing arm that has it. So it doesn't depend on even if you're right or left-handed. It's usually the trailing arm. It's because a lot of patients end up with this cocking kind of motion. And so there are three typical movement patterns, and I'm sure Tim can also elaborate on this a little bit more, that cause epicondylitis. One of them is casting, where instead of actually having their elbows kind of up and when they're coming down through to cock and coming down into the nice swinging motion to make sure that your arms are straight when you have contact with the ball, if their arms are a little bit further out from their body, instead of using the rotational motion from their shoulders, they're using basically the weight of the club head to try to swing through. They're not actually tensing their shoulders appropriately. They're not using the rotational momentum to actually hit the ball appropriately. The other one that's actually listed here on the slide, that second picture down, is actually called scooping, where you're trying to basically scoop the head of the golf club through the ball. And when that happens, you're actually putting more strain onto the medial epicondyle than the lateral. And you could see that you're trying to use your back arm in this picture to kind of move the ball forward, as opposed to having it nice strike through and swing through on the ball. Because remember that the golf club head is also angled for you to be able to strike it appropriately and straight on, no matter like with the appropriate swing. The last one is actually kind of funny, and I couldn't find a very good picture for it, called chicken winging. So when you finish your swing, a lot of times that lead arm ends up kind of chicken winged out, or the elbow kind of protrudes out. And that also, it takes the stress off your leading arm, which is nice, but also puts a lot more strain onto that following arm or the trailing arm, which causes more stress on the medial epicondyle, causing more inflammation into the tendons. And if you repeat it over and over again, unfortunately, you do cause a lot of irritation, and which leads to medial epicondylitis. Next slide. So how do we diagnose this? We usually talk with the patient first. I want to know what kind of history you've had. Are you playing golf a lot? Are you new to the sport? Do you have a job that really requires you to use your elbows, use that gripping and turning motion a lot? We have a lot of things in our toolkit for our clinical exam, the main one being tenderness over that medial epicondyle, or like that inner side of your elbow. Sometimes we'll also do pain with wrist flexion or wrist extension. Sometimes you'll have pain with wrist pronation or supination. Remember that muscle that's responsible for bringing that palm down. So we'll try to test it in both directions to make sure that you still have appropriate strength. Sometimes you'll have pain with gripping, because those tendons that also grip attach down into your medial epicondylitis, or medial condyle, sorry. And then there's something called a modified book test, where we try to see if you could actually hold a book up with your wrist flexed in a pronated position for a short period of time. And that's supposed to test basically the strength of those tendons attaching into that area again. It looks like on the chat they said, will a copy of the video be present? I believe it's going to be posted to YouTube afterwards, and you should be able to find it there for the foreseeable future.
Yeah, we'll send the link.
The other things that we do have for our toolkit are directly in office. A lot of the sports medicine providers will actually have an ultrasound, so they'll be able to take a look at the tendon as it comes in and attaches. So the image on the left is actually a normal medial epicondyle with the common flexor tendons attaching in. And you can see kind of those fibers come straight across that white line that's down below the bone. And it's very nice and straight. There's no extra fluid, there's no extra dark spots. If you look at this medial, the middle image, you can see that, you know, the bone is there right in the bottom left-hand side of that middle picture, but you can see that there's this yellow arrow there that shows that we have a little bit of calcification in that area, and the fibers no longer run kind of straight across the stream from right to left. There's a little dark spot there where it's showing that it's not quite as continuous, meaning that there's some inflammation into the tendon, meaning that there could be some damage into the tendon. And then possibly there's a small tear in the tendon. That all the kind of stuff that we want to look at as far as diagnosis and treatment and seeing how well you're improving as well. The last item in our toolkit for imaging is an MRI, which oftentimes we don't jump for because it won't really change a lot of the management, but it is sometimes good to see. And it does show some inflammation. There's that white arrow right on the picture that shows some inflammation of those common tendons attaching down and into the medial epicondyle. Next slide, please. Excuse me. So how do we treat this? The mainstay of our treatment is physical therapy with eccentric exercises. Eccentric means that we're kind of stretching out the tendon as we exercise the muscle itself. So if we stretch and strengthen at the same time, a lot of times that preserves the motion of the muscle, number one. And number two, it exercises the muscle in the safest way possible. If we were to shorten the muscle, what we call a concentric exercise, usually that generates a lot more force, but can be more deleterious or damaging to the tendon, especially when you have some sort of injury. There are braces that we can use in this area. We call them counterforce braces. And the idea behind this is if we kind of put another pressure point that's a little bit more in the middle point of the muscle as opposed to right at the tendon, then the muscle only acts straight up to that area where it's being compressed. And we can give that tendon some time to rest on its own and try to heal on its own. Sometimes if you have a mild case, we try to do some just general anti-inflammatories. So if it's the very first time you've ever had it and it's only been going on for a week or two, sometimes we give you a short course of anti-inflammatories like ibuprofen, Advil, Aleve for about a week or two, just to see if we can calm it down. And then from there, we try to modify your activities. We try to take a look at your form, try to see if you need maybe a coach, try to see if you need to change your grip widths to see if something can work out and prevent you from having it recur. There are also a number of injections that we can do in this area. Sometimes we'll do a cortisone injection in this area, sometimes ketorolac, which is a non-steroidal anti-inflammatory again, and sometimes platelet-rich plasma, which is a good option as well, which has been shown to show a little bit of tendon healing as well. Like I mentioned, we can do some activity modification, form coaching for golfing, for tennis, that kind of stuff, as well as grip adjustments. Sometimes if you work as an electrician or a mechanic or a carpenter, we beef up those the grips for your tools. And it does tend to help because you don't have to grip quite as hard when you're trying to make that rotation motion. There is some research and novel research showing that nitroglycerin patches can increase the blood flow, increase oxygenation and nitrogen in this area, which can help tendon healing. We try to use that in conjunction with all the rest of these. Nothing actually kind of inhibits another. And so it's actually a pretty good option for patients who have tried some other things, but aren't quite all the way there. And then finally, if you fail 12 months of the conservative management, then sometimes we will recommend surgical intervention. A lot of times the previous interventions were not optimal. And so we try one or two of them again, just to see if there's any other options, to see if we can try to ensure that you were getting the most optimal treatment. But for some patients, if the pain is too much, if it's been going on too long, sometimes we recommend surgery. Next slide. Oh, it looks like it's Tim's turn.
Yeah. So for the members and the the guests in the webinar, if you play golf or have had some type of elbow injury, just put that in the chat window just so we can get a sense of who our guests are today, who our respondents are. But in the meantime, Tim, take it over and talk about your expertise and how you manage some of these patients.
Yeah, so thank you, Dr. Lee, for that in-depth analysis of the anatomy. That was super helpful. And thank you, Dr. Singh, for the reintroduction. I kind of wanted to dive into a little bit of what we see here on the physical therapy side of things. So this slide here goes a little repetition of what Dr. Lee was talking about, so I'll go through it quickly. Main cause is just going to be your overuse and repetitive microtrauma. Mainly, specifically for golfers, is going to be when, you're not playing for a long period of time and you go out to the driving range for the first time and you just take a million swings back to back. That's going to initially cause those micro tears, which is where your injury is initially going to start. So this could also be from, like Dr. Lee was talking about, in terms of the grip. If your grip is too small, you might be gripping the club a little bit too tightly, which can cause a little bit of excess force through those muscles, which is where that kind of inflammation is going to start. So what's it feel like? A lot of our patients tell us that they're going to come in with some dull, achy pain for the medial epicondyle that's located on the inside part of the elbow. So right about here, they're going to be complaining of this dull, achy pain that can sometimes feel like a little bit of a burning sensation. And again, it's exacerbated when they're doing things that require them to use those muscles, whether that be, gripping and lifting, or even, brushing their hair or texting. And I bring those things up because that's often the first thing that we're going to tell patients to do to limit their pain. But we'll get into that in a little bit. You can go to the next slide. All right, so here we see Tiger going through his swing sequence. And I highlighted the part of the swing that you're going to see this come into play. So Dr. Lee, I think you did a great job of kind of talking about that casting and kind of how this actually comes into play and when during the swing those muscle fibers are going to be actually activated. One thing I wanted to add is when we go through a TPI screen, basically what that is it's a full body analysis to see if there are any faulty mechanics elsewhere throughout your body or throughout the swing that may be causing excessive compensation elsewhere. All right, so a lot of your power is generated through those hips and your core, and it's going to go all the way down the chain, ultimately to the club head, which is going to send the ball hopefully 300 yards down the fairway. So yeah, that's kind of right where you see Tiger in that downswing to impact is really where you're getting a lot of wrist flexion and pronation of, that would be his right elbow. All right, so you can go to the next one. All right, so here we have the non-surgical treatment. All right, so like Dr. Lee was saying, we don't really see this ending surgically very often. Rest and activity modification is the biggest treatment that is going to help. Mild cases, you're going to see your anti-inflammatories, Advil, ibuprofen, corticosteroid injections. That is naturally an anti-inflammatory. And a lot of cases we'll actually see this used in conjunction with physical therapy. That's pretty much, I've seen the best results with patients who have been like, oh, this is hanging around for a while. Let's try a steroid and start loading those muscles so they're able to handle the forces that we need them to.
Can I ask both of you guys a question? Tim,
Yeah.
Caroline. The first one you mentioned for non-surgical treatment is rest and activity modification.
Sure.
How successful are you in telling a golfer to not golf and to hold off on it?
I'll say almost as successful as I'm telling a runner not to run, which means not very successful.
About the same.
No, I asked that because I suffer from golfer's elbow and tennis elbow, and it's always during the springtime, and I'm not resting. I was like, I'll just deal with it in the winter. So I know it works because I have not golfed in the last 3 months because I was training for a run, and I have 0 symptoms. So it does work. It's just prevention, which we're going to talk about.
It's tough because you want to be out there playing, especially on those 75 and sunny degree days. But
that's right.
But yeah, it's tough. So you can go to the next slide. All right, so what are we going to see, or what are we going to do in a physical therapy session, right, when you come in? So essentially, we're going to do our evaluation. Part of like a golf specific evaluation, I always add that TPI screen. Thank you, Tom. So basically, here's what we were just talking about. So your activity modification is going to be bringing it back to looking at your functional daily activities. So you want to modify wherever possible. So if you're going to the grocery store, you're carrying home, a 10-pound bag. If you're experiencing symptoms on the right hand, you're going to want to try to modify and let that left hand take up some of the work while you're resting that right hand. Things as easy or as mundane as texting every day, right? You want to make sure that you're looking at what the position of the wrist is while you're even texting. Now, the biggest thing right off the gate is pain reduction. So in addition to some of the things that we were talking about before, including the NSAIDs and the steroids, we can use modalities such as ice, e-stim, ultrasound to help to kind of calm down the tissues and help to reduce some of that swelling that's going on in the tendons. We'll definitely do a postural assessment. A lot of the TPI analysis is postural in nature, just because Dr. Lee can speak to a lot of golfers will sometimes present with, well, I should say oftentimes present with some type of back pain, just because there's a lot of torque going through the spine and the core throughout the golf swing. So we want to make sure that the golfers are going to have the amount of the proper range of motion to get through those that swing properly. And in terms of what we're going to be actually kind of addressing is we may do some soft tissue massage again to help to flush out some of that inflammation, calm down those tissues a little bit. In terms of the flexibility, if those tissues are irritated, they may get a little bit tight, which is where we may want to stretch them out. And part of the eccentric loading that Dr. Lee was talking about before incorporates stretching and strengthening together, which is why I would say that's the most effective treatment for this is going to be, rest, pain or activity modification, and then strengthening the wrist flexors and pronators eccentrically. I said I wrote down shoulder and elbow there as well. You're going to want to not just treat the wrist here. Like I said before, the golf swing culminates the whole body. So we don't want to ignore what the elbow strength looks like, what the wrist or what the shoulder strength looks like, especially what the core and even the glute strength looks like. Things like you may not even think about that, but we definitely want to see what that looks like just to make sure that the wrist isn't overcompensating from lack of whether it be range of motion or strength elsewhere in the body. And then finally, we want to look at return to sport, right? This is the most overlooked phase of rehab. People are like, oh, my pain's gone. Let me get right back out there. One of those people probably being Dr. Singh. So during the return to sport phase, these are some of the things we're going to address. So plyometrics is more kind of explosive movement, endurance, and then power. How do we drive the ball a little bit farther? You can go to the next slide there.
Can I ask you a question real quick? We talked about TPI a little bit earlier.
Sure.
You certainly have certifications in TPI. What is that? What is TPI? How important is that for if we see a golfer or someone with medial epicondylitis in clinic? How does your approach differ from another physical therapist that may not have the same certification? Just go into a little bit about what TPI is, if you don't mind.
I think the biggest thing is going to be the language that we're using. I think golf in particular, as a sport, has a lot of specific language that maybe a TPI specialist might be able to talk more fluently with a golfer than say your average physical therapist. I think you would be able to achieve similar results. I think you would just be able to kind of speak the language a little bit better with a TPI specialist. And basically what TPI is it's a program that was developed by a physical therapist and a golf swing coach who came together, and they realized that what are all these golfers that are getting hurt and getting rehabbed, what are they doing, and came up with an approach that kind of breaks down specific body mechanics that may be causing some of those compensations that I talked about before. For example, one of the screens looks at ankle mobility. So if someone coming in with elbow pain, this screen every patient, we're going to take them through this 16-part screen to see what their full body motion looks like, and see maybe it may be your ankle range of motion that we're addressing that can ultimately lead to having a pain-free golf swing, no more elbow pain. Not ultimately a lot of the cases that I see with elbow pain, but you can get the gist there. So it's a functional movement screen that the PT and the golf pro came up with together to ultimately address a lot of these players' concerns and comments. Okay. Does that make sense? Questions on that? Cool.
No, that's helpful. That's helpful.
So what I was talking about here is in the return to sport phase, we want to talk about tolerance of resistance exercise progression. So sets and reps are going to be influenced by what you're trying to achieve, right? So things like strength and power, you may have fewer repetitions and fewer sets, versus if you're going to look at endurance of a muscle, you may have higher sets, higher repetition, right? But really it should be sport specific. That's the biggest thing, is depending on what we're trying to achieve is what you should be doing in your rehab. Okay, you shouldn't just be doing wrist curls every time. We should be addressing that full chain up and down before you actually get back onto that driving range or golf course. Alternating days with rest in between is also important. You want your body and the muscles to be able to grow and hypertrophy, and rest is a huge component there. And it decreases the potential for re-injury, right? And then finally, the inspection of sports equipment. So this here is what Dr. Lee was talking about in terms of grip, clubs. You may want to, if you're really into golf, get fit for clubs, and the golf hitting pros will be able to look through or break down your swing, like we looked at Tigers before, and see what club might be best for you.
Let's talk a little bit about grip. That comes up in tennis sometimes too. What do you mean by modifying the grip, and how does that help with symptom management or even treating the condition to begin with?
Sure, yeah. So grip can be different kind of diameters, and if a grip is too skinny and you're kind of gripping the club too hard, it may not even be the actual grip that you're using. It may be how you're gripping the club. So if you're gripping the club kind of like this, it's called like a death grip, right? Then that is not great, because you're activating those wrist flexors a lot more than you should. This is kind of the grip that I use. It's a little bit more relaxed in the wrists, right? Which is going to allow the rest of that kinetic chain, meaning the glutes, the core, to do more of the work, and allow the wrist muscles to really just control what the club is doing.
Yeah, what I sometimes tell patients, and Dr. Lee, you can correct me also, is imagine gripping a pen really hard. How hard can you grip a pen to prevent me from pulling it out of your hand? You have to grip that really, really hard, versus gripping your forearm. You can put a lot more pressure on a thick forearm than you can with a pen, and the same kind of true for the golf club. If the grip is too thin, you're going to add a lot more force to it, which is why you even see, Bryson made all of his grips really big just to release some of his grip strength. Dr. Lee, I want to go back to you. You asked a question about steroid injections. We get people coming in all the time saying, hey, I got a golf thing with my buddies or a tournament. Give me a steroid shot, make me feel better. I want to play in this thing. What are your thoughts about steroids for this condition, pros and cons?
So the one main pro is that a steroid is a powerful anti-inflammatory. It'll give you a lot of good relief. It does take a couple days to kick in, so I wouldn't recommend doing it the day before doing something like this. But the limitation is basically that steroids can decrease tendon strength overall with time. And so I hesitate to give you more than 1 or 2 injections at the same area, because I could cause a tendon rupture. To that end, I would try instead to convince you to do the non-steroidal anti-inflammatory ketorolac, or to continue with physical therapy to see how well you do, or to try another conservative measure like a nitroglycerin patch to try to increase the blood flow in this area, combined with the eccentric exercise, combined with the form, to try to make you better overall. I'm always worried about causing any sort of tendon rupture because you already have a tendon. I don't want it to rupture and potentially set you back even further.
And if you do opt for the injection, how important is it to use ultrasound guidance versus just doing kind of palpation, feel where it hurts, and putting the needle in? What are the risks there?
So I like the ultrasound guidance in my own practice in particular, because I like being able to visualize the tendon. I like being able to go through and look at all parts of the tendon itself to see if it's more lateral, more medial on that, well, I guess more anterior or posterior on the medial epicondyle, and trying to look at the tendon itself. Does it look like it's very chronically in the tendonitis, so tendinosis picture, instead of very acute? Do you have a lot of small micro tears there that would concern me for potentially a larger rupture? Should I be putting medication there if you do have a partial rupture, a partial tear? And that would be those things that are always helpful with an ultrasound, so that I could check it real time. I could check and see if it corresponds to where you're having the most pain, and I could try to seat the medication into areas where I think it'll do the most good. Yeah.
A question came in from the chat. Have you found BFR? BFR stands for blood flow restriction.
Yeah.
Have you found that useful in epicondylalgia? So have you guys answered that, Dr. Lee and then Tim?
So the research for blood flow restriction is interesting, but not quite conclusive as of yet. The sample sizes are relatively small, meaning they don't have a large population that it's testing. It does increase the amount of inflammatory markers, which would technically help in spurring the body's healing process along, depending on the individual. I would hesitate to say that you should use it all the time or that it should be your mainstay of treatment. Excuse me. I think overall it's an interesting concept that I'm going to keep an eye on, but it doesn't have any conclusive research as of yet.
What is it? What does that actually mean, Tim? What is blood flow restriction? What is that? What are we talking about?
Yeah, so essentially what you're doing is you're using, they look like kind of blood pressure cuffs, and you're applying those proximally, meaning closer to your heart, and it's going to restrict the amount of blood flow back to the heart. And actually, I found in my practice that the best results that we've gotten for these is with post-op cases. Post-op knees, we don't really see a ton of, we don't really use this very often for medial epicondylitis. And yeah, the research really just is not as conclusive. A lot of the research talks about total knee replacements, ACL, meniscus repairs, but not too much research on elbow with BFR.
I think the other interesting thing about it is there are a couple of studies done that show that if you use the blood flow restriction, not even on the same limb that underwent the surgery, it actually provides the benefit for both sides, which then kind of calls into question what's going on. But it's an interesting concept overall.
We in medicine, unfortunately, we kind of wait for patients to develop problems until we see them, and then we try to help them recover from this condition. And it's unfortunate that we can't really talk more about prevention. But after you see these patients, both in clinic and after therapy, what are some tips that you tell them on things to do, whatever during the off season or after they play golf, to prevent this from recurring? What are some of the best tricks and strategies? Either one, Dr. Lee or Tim.
Sorry, can you repeat like the beginning of the question?
Just in terms of prevention, we wait for people to get sick and then we help them, but we don't often get a chance to tell them how to prevent this from happening in the first place. So what do you tell patients on how to prevent this from recurring?
Yeah, so biggest thing from the therapeutic standpoint is when you're going to do that activity again, say it's the first time you're going out in the spring, I think going out and taking a few swings at the driving range may be better than going out to play 18 the first time. And the reason that is because if you go from 0 to 100, that's exactly how the overuse, this is how this whole injury happened in the first place. So progression of the repetitive exercise would be my greatest advice.
I also try to tell patients to keep up with their exercises. Once they've had it, they're more likely to have it again. So any sort of exercises that they have gotten from their former courses of physical therapy or occupational therapy, I try to tell them to keep up with it. It's kind of like homework or something easy to add in when you're doing your normal workout. Just 10 minutes of kind of doing your eccentric exercises, your grip strengthening exercises, and then kind of postural control too.
Question came into the group about EPAT or shockwave therapy, pulse activation therapy. What are your experiences with treating medial epicondylitis or any epicondylitis with these types of treatment modalities?
So I can take that one. So Shockwave, we don't have that machine in our clinic. I've never used Shockwave, but I have some friends that are chiropractors as well as other fellow physical therapists that have seen success with this. I don't have specific numbers for you, and like I said, I haven't tried it personally. Things like ultrasound and electric stimulation are modalities that can help, but not things that you'll see long-term success with.
So I don't do it personally myself, but from my understanding with conversations with other practitioners that do use the shockwave therapy, it usually takes anywhere between 5 to 8 sessions to really have some sort of benefit. They are working on some research studies for tendinoses, tendinitises, to see what kind of dose benefit there is, how long it does take, and in conjunction with what other treatments optimizes each patient. But that I think is going to be hopefully complete in the next year or two as far as research studies go.
Yeah, we offer shockwave therapy here at Weill Cornell, both on the Upper East Side campus and at Lower Manhattan. And basically the theory behind extracorporeal, which means outside of the body, shockwave therapy or pulse activation therapy, basically these are areas where you don't get much blood flow because they're tendons. It's where the muscle turns into the tendon and turns into inserting into the bone. So there's not much blood flow there. So the theory is that by stimulating these tendons, shocking them, causing some quote bleeding inside the tendon, you bring in nutrients, you bring in oxygen, you get rid of some free radicals and inflammation and help that tendon recover. So we've seen, fair results for things like plantar fasciitis, for Achilles tendonitis, which is the back of your heel, for tennis and golfer's elbow or medial lateral tennis elbow epicondylitis. I agree with Dr. Lee. I think the research still is TBD, but it is a treatment option if some of the more conservative things are not providing benefit. I'm looking through these questions. You mentioned a PRP for this, for treating tennis or golfer's elbow. What is PRP? What does that mean? And what would patients expect from that type of treatment?
Yeah, so PRP is platelet-rich plasma. It's a sample of your blood, and we spin it down and try to isolate the platelets. Platelets are classically known for, making clots after we get a cut, but they're also very good at recruiting other factors, other cells to start laying down tissue fiber, like a network, basically to help and spur on a little bit of healing. So the idea behind it is if we isolate the platelets and we inject into an area that, like you said, doesn't have a lot of vasculature, a lot of blood vessels in the area, like a tendon, particularly around the medial or lateral epicondyle, we could spur on a little bit more healing because those platelets will automatically recruit more growth factors, a couple of inflammatory factors to try to heal that tendon. And there is some research that shows when put into joint, it puts down a little bit of fibrous cartilage in that area, which lasts usually about a year or so in animal models. In human models, obviously, it's a little bit harder to do because then you'd have to extract it. But it is relatively safe because it's your own blood. And so not a lot of reactions there. The only thing is that it's a pro-inflammatory response. So if you did have PRP, you would expect to have a little bit of extra pain in the area, kind of like a dull ache, for about a week or so. Depending on the part of the body, we tend to do 1 or more injections. So for the medial epicondyle or lateral epicondyle, protocols right now are 1 to 2 injections. For larger joints like a hip or a knee, sometimes it's up to 3 injections. But obviously, if you feel very good after your first injection, we don't have to do much further.
I mean, it sounds like overall from both of your approaches that it's the conservative treatments that tend to work the best, that have the most longevity, you know, working on ergonomics, working on posture, fixing the other down the chain segments, whether it's the wrist, further away from the elbow, or it's the shoulder and the core, closer to the body, which is nice because it means most people can fix this without getting expensive interventions or even a surgical treatment. What are some final thoughts, some closing remarks, things that we didn't touch on from either one of you? Tim, go ahead and go first, and then Dr. Lee, and then we are coming to the close of our session. Go ahead, Tim.
Sure. I would say, you know, at first, if you start noticing this, you know, seek help as quickly as possible. Couple words, I don't know if we addressed it earlier or not, but this can turn from an itis, which just means, itis means inflammation, but that's more of an acute inflammation, to osis, which is just chronic inflammation. And the more chronic this becomes, the harder it becomes to treat. So the earlier you can get on top of this, the better. And yeah, reach out for some help.
Thank you so much.
Yeah, I guess my closing remarks would be, for the most part, conservative treatment is best and has the most research behind it. And to that end, it's always worth trying another round of conservative treatment before jumping for anything else. And sometimes if you do have that severe pain, an injection is worthwhile to do, such that by the time that the injection wears off, you've done some physical therapy, you've done occupational therapy, and your tendons and your muscles are strong enough to support the activity that you want to do. Our job is always that we want you to get back to what you're doing. We don't want to hold you from it. We want you to golf. We want you to play tennis. We want you to lift. We want you to do everything. So let us help you. We'll do our best.
All right, wonderful. Thank you, Drs. Lee and Caputo. Thank you all to all of the guests that we had on our webinar. Great questions that came in through the chat. If you do have questions, these are the 2 phone numbers to contact. We are still figuring out the agenda for the next webinar and the next topic. If you have ideas, please share them with us. We are happy to create a small little webinar for you. You are our audience. We work for you. So thank you, everyone, in joining us in the Rehab webinar series. Hope everyone has a good night. And thank you to the speakers. Take care, everyone.
Take care.